The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
Welcome to Your Health, Your Choice. Tonight, we are pre-recorded again because, since the COVID pandemic situation, we've been pre-recording the program. So up to last year, we were doing live programs, so you could call in with your questions. But so at the present time, we give you a telephone number, which you can preferably WhatsApp your questions on 482-4269. That number will keep coming up on the screens. It's my office number, but I use it as well for messages, etc. And we try to respond. I'm not going to talk tonight about the pandemic, COVID-19. What I would encourage you to do is to listen to the media conferences, the media briefings. I was listening to one just before doing the program today. And it's a situation that's in flux, constantly changing. We're going to talk tonight about prediabetes. Now, on the last program, last two programs, the one about 4 weeks ago, I did the latest updates from the American Diabetic Conference, which was virtual, of course, this year. And then last week or 2 weeks ago, I looked at some of the guidelines from the American Diabetic Association. Now, I was going to continue that, but just today I changed, and I thought I would focus in on what is called prediabetes. Now, why am I talking about prediabetes? Of course, my basic training is as a family physician, and then I did diabetes as a subspecialty, community-based diabetes. And the whole emphasis there is to recognize or to highlight people who are at risk of getting diabetes, or those who are in a pre-diabetic state. So there's something called prediabetes, or some people call it glucose intolerance. So then the names are interchangeable, prediabetes or glucose intolerance. And the important thing about this is that up to maybe 5 to 10 years before someone develops diabetes, we see a progressive rise in the blood sugars, as I'll show you in a few minutes. And we know that that is the time where we can intervene. And many people come in and ask me, after having had diabetes 5, 10, 15 years, can they come off their medication? Can they go on herbal supplements? Can they reverse their diabetes? Can their diabetes be cured? Well, what I would say to you, that's precisely why I'm doing this program tonight, because if you can recognize that you're in a pre-diabetic state, that is the point where you can intervene and you can see reversal or even remission from a pre-diabetic state to a normal glycemic state. So what we want to do today is define what we mean by prediabetes or glucose intolerance, and then look at some of the figures, some of the blood sugar readings, and then look at some interventions to try and reverse this trend. Of course, diabetes is an epidemic. So we're talking about the COVID-19 pandemic, which is worldwide, but diabetes as one of the non-communicable diseases, the NCDs, is also a pandemic because it's worldwide. And, with all the concerns about COVID-19, sometimes we are overlooking the need to continue delivering an adequate level of care to our diabetic patients, or people with what we call the metabolic syndrome, which is a combination of diabetes, hypertension, hyperlipidemia, and very often coronary or cardiovascular disease. So the first slide I'm going to bring up is slide 1, and it's just telling us again about what tonight's program is going to be all about. Slide 1. What is prediabetes? So that's a question we're going to answer first. What is prediabetes? And lower your weight. So on the left-hand side of the slide, lower your weight and lower your risk. So I just want that image to kind of be imprinted on your mind, but I'm going to come off that for a minute and say that that's only part of the equation. So lowering your weight is obviously very important if you're pre-diabetic, but some people are actually normal weight. Their BMIs are good, it's within the range, and yet they're in a pre-diabetic state. So that's where I begin to tell people that pre-diabetes and diabetes is not just a lifestyle problem. So what I find is a lot of patients coming in and they define their diabetes by simply what they eat or their lifestyle. So they say diabetes, and I often hear healthcare professionals or people on the radio and television saying that diabetes is a lifestyle problem, so it can be reversed just with diet alone or just with exercise. And I say that's a misunderstanding of what diabetes, although I'm talking about pre-diabetes, it's a misunderstanding of what diabetes is all about. Diabetes and even pre-diabetes is very much also a genetic condition. You are genetically predisposed to getting pre-diabetes and diabetes. Now, the big question is pre-diabetes a medical condition? So this is often discussed in international circles, scientific conferences. Should we define pre-diabetes as a medical condition, which then will bring millions of people, or in Trinidad, maybe, we have about over 100,000 people with diabetes, about 12 to 15% of the population, but we're estimating another 15% of the population, 15 to 30% of the population may be already pre-diabetic. So you're talking about another 200 to 300,000 people. Is that going to overwhelm the health service? Can we really deal with treating pre-diabetes, or does pre-diabetes need to be treated? So the second slide poses the questions. What is diabetes and pre-diabetes? What are the risk factors for diabetes or pre-diabetes? And how can you, so the third question on that slide, how can you delay or prevent diabetes? How can you delay or prevent type 2 diabetes? That is the key question that we're going to answer tonight. So, of course, we know what diabetes is. Diabetes is a condition where your blood sugars are higher than normal, and I'll define what I mean by that. And not enough insulin is being secreted by the pancreas. So there are two basic pathophysiological problems. Your pancreas, of course, is not producing enough insulin, and the insulin that is being produced, your body is resistant to that insulin. So that's what is called insulin resistance. Now, of course, there are several other pathophysiological causes, which we call the ominous octet, but I don't want to make this too complex tonight. I just want to say, make it narrow it down to these two basic concepts. You have insulin deficiency, and then you have insulin resistance. But the thing about pre-diabetes is that actually in the pre-diabetic phase, your pancreas sometimes is producing more insulin than needed. You're in a hyperinsulinemic state. Hyperinsulinemic state. Your body is producing more insulin because it senses that the body's struggling to cope with the sugar levels in the blood, and the pancreas is beginning to really be overactive. And as a result of that, you can wear out the pancreas at an earlier stage. So if we were to look at insulin levels, and these are famous slides that we show when we're giving talks on pre-diabetes or even diabetes, that up to 10 years before you develop diabetes, and if you were to measure insulin levels, which is not that easy to do, you could recognize that it's you're in a hyperinsulinemic state. Your body's producing too much insulin, and that has consequences as well. When your body's producing too much insulin, excessive insulin in the system, some people think it's linked to cardiovascular disease. weight gain, etc. But I don't want to make that too complex tonight. Now, I want to bring up slide 4 before we dig into prediabetes. Slide 4 shows basically the types of diabetes that we talk about. So type 1, of course, usually, and the reason I show this so often is that very often people ask me, am I a type 1 or type 2 diabetic? Well, type 1 diabetics usually diagnosed in children and young adults, but don't be diverted by this, because there are some people in their 30s and 40s that can present with type 1 diabetes. Type 2 diabetes is by far the most common form of diabetes, and it comes on more in later life. But when I say later life, we are having to change that kind of terminology, because we are seeing some teenagers with type 2 diabetes because of overweight, insulin resistance, very strong family histories. But type 2 diabetes is by far the most common form of diabetes. Over 90% of people with diabetes would have type 2. And then, of course, we have gestational diabetes, and that's originally what the program tonight was going to be about. But gestational diabetes is diabetes that occurs in pregnancy. So, I had a patient on Saturday, and we had to define very carefully for that patient, was this gestational diabetes or was it diabetes coming into pregnancy? And there's a big difference, because if you are diabetic and you are planning to get pregnant, what we usually say is that we would want you to come in and start getting preconception advice. So up to about 3 to 6 months before planning the pregnancy, if you are diabetic, a female diabetic, you come in and we start giving you advice. We start talking about the possibility that you may need to be on insulin in your pregnancy, because right as of this point, metformin is probably the only approved oral hypoglycemic that can be used in pregnancy. So most times people who are type 2s will have to be converted to insulin, and sometimes we do that even before the pregnancy, or at least in the first trimester. But gestational diabetes is diabetes that is diagnosed in pregnancy. And I'm not going to go into the figures today, but the figures for gestational diabetes is much lower for diagnosis than for type 2 diabetes. So, for example, most of the guidelines would say if you have a fasting blood sugar in pregnancy of above 93, that's diagnostic of diabetes. And if your 1 hour value is below 160, or your 2 hour value is below above 140, that's diagnostic of gestational diabetes. And one of the important things I want to remind you is that if you have had gestational diabetes, you should be checked every 2 to 3 years with a fasting blood sugar or an A1C, because maybe over 50% of people with gestational diabetes will go on to develop diabetes later on in life. Okay, so we're going to go on to slide 9 now, and we're going to really define, drill down into what is prediabetes. Prediabetes comes on before type 2 diabetes, of course. So we don't talk about prediabetes in type 1 diabetes. We talk about prediabetes in type 2. Blood glucose levels are higher than normal, but not yet diabetic. And you can have prediabetes and not know it. Now, that last sentence is extremely important, because the fact is you can have diabetes and not know it. So, a lot of people would say to me, well, doc, I feel completely well. And they went in for a routine medical, or went in for another medical problem, and the doctor happened to do a finger prick test, and the blood sugars were over 200 or 300, and the patient was absolutely asymptomatic, no symptoms at all. So that also applies to prediabetes. So, I use the example of now you do your car checks. If your car is above a certain age, you have to, every 2 years. I just realized my cars need to be have it's a 2-year, and it's called MOT. That's what it's called in the UK. But the 2-year check for your car. Now, your car might be working perfectly well, but you take it in for a check to make sure that the brakes are working, the handbrakes, the lights, all the other things that are checked. So it's a similar thing with pre-diabetes. You may have no symptoms at all, but you may have pre-diabetes. So what are the kind of levels we are looking for? How do we diagnose pre-diabetes? I'm not sure how many more minutes we have before the break, but I'm going to show this next slide, which is slide 10. Slide 10. So slide 10 gives you an idea of what is pre-diabetes and what is diabetes. So if your fasting blood sugar is below 100, that's normal. That's the green area on the right-hand side of your slide. There's an arrow there. So if your fasting blood sugar is below 100, that's normal glycemia. If you're between 100 to 126, 100 to 126, that's the yellow area. That's defined as pre-diabetes. And if your fasting blood sugar is above 126, then that's frank or overt diabetes. So we can just come off that slide again. And so that slide defined prediabetes basically on the basis of a fasting blood sugar. But there are two other ways of diagnosing prediabetes. Now, I just want to say at the same time, this is not on the basis of a finger prick test. So although you might be fasting overnight and you do a finger prick test, even if it comes back as 110, 120, I would be hesitant to define you as pre-diabetic until you go to a lab, a proper lab, you fast overnight. Usually it's about an 8 to 10 hour fast from about 10 p.m. You fast overnight and you can have water to drink, nothing to eat after 10, and you go to a lab and you have a finger prick test and you do the blood sugar. When we come back from our break, I will tell you the two other ways of diagnosing prediabetes, because very often the fasting blood sugar could be in the normal range, but when we do what is called the glucose tolerance test, or we do the HbA1c, which is the glycosylated hemoglobin, then that throws up a different picture. So we're going to go to our first break. We're on Your Health, Your Choice. Remember the number to WhatsApp your questions on 482-4269, 482-4269. We'll return in a minute or two to Your Health, Your Choice.
Cloud9 with your new hosts, Renata and Kimberly Singh. Weekdays at 5 p.m. on ACTN The Voice.
You're watching ACTN The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice. You're watching ACTN The Voice.
Welcome back to Your Health, Your Choice. Just to remind you, we are on a these programs are now pre-recorded, so you can't call in with your questions, but you can WhatsApp us, preferably WhatsApp rather than ring in on 482-4269, 482-4269, and I would actively encourage you, if you have questions, particularly tonight on prediabetes, you can do that, and I try to return the WhatsApp messages as best as possible. So we've been talking about prediabetes, and just before the break, I showed you a slide looking at defining prediabetes. And remember, prediabetes is a state, and yeah, thanks, Josh. So we showed this slide looking at a fasting blood sugar of below 100, defined as normal, the green area between 100 to 126, that's called prediabetes, and above 126, we defined as diabetes. However, the point I was about to make is that's one way. And by the way, as I said, that's not on the basis of a finger prick test. That's on the basis of fasting overnight and then going to a proper lab and getting your blood sugars done. And there are two other ways, though, which I often go for as well if I'm trying to define someone as pre-diabetic. It's called a glucose tolerance test. So that's where you go fasting overnight, and then we do a fasting blood sugar. We give you a 75-gram glucose drink, and then we do a 1-hour test and a 2-hour blood test. So again, if the fasting blood sugar is between 100 to 126, you can diagnose diabetes there. And then the 2-hour value. So we look at the 2-hour value with the glucose tolerance test. If it's between 140 to 199, that is defined as prediabetes or impaired glucose tolerance. The third way of diagnosing prediabetes or impaired glucose tolerance is the HbA1c. So, often we talk about the HbA1c being used in diabetes. And of course, that's the glycosylated hemoglobin. It's the glucose oxidizing certain aspect of the red blood cells. So the red blood cell has a time lifespan of 3 months, roughly. So it's giving you an average, a memory of your blood sugars for the last 3 months. And if your A1C is between 5.7 to about 6.4, that's defined as prediabetes or impaired glucose tolerance. So there are 3 ways of defining this. And I think the reason I labor this point is I personally feel that doing a fasting blood sugar on its own in people who are high risk, now I'll define what I mean by high risk in a few minutes. I don't think doing the fasting blood sugar is good enough. I would encourage people who are high risk to do the glucose tolerance test and the HbA1c. So, because, it's incredible how often I see a normal fasting blood sugar, but when we do the glucose tolerance test or the A1c, we see that it's elevated and it's pre-diabetic. So, slide 11, I think it's slide 11, asks the question, what is your fasting blood sugar? And some of you may say, well, I don't have a clue because I've never done it. So the other question is, when was your glucose last checked? When was your glucose last checked? Now, I know nobody particularly likes to, finger prick, do the lancet and pricking the finger for blood. No one particularly likes doing blood testing, but there are certainly patients in certain groups, and that's what I'm going to get into now, who should be doing a blood sugar reading every year or every 2 years. Now, of course, if you're diabetic and you're not well controlled, you should be doing regular home blood sugar testing. The latest guidelines would say that if you're diabetic and your A1C is around 6 to 6.5, then maybe you don't need to do frequent home blood sugar testing. But I think it's a good, there's something about good habits. And so I come back to a bit of a philosophical take on this. While, if your blood sugars are, your A1C is 6 to 6.5, the doctor may say, oh, if you come to me, I might say, well, you don't need to do frequent home blood sugar testing, certainly not 3 and 4 times a day. But I still think it's a good discipline once every few days to do a blood sugar testing, because it just keeps you aware that this diabetes is still in the background. It doesn't have to overtake your life. You live a normal, healthy life. Remember, this program is called Your Health, Your Choice. The choices we make today will determine the stories we tell tomorrow. That's part of a sermon I preached a few weeks ago at our church. The choices you make today. But so where your health is concerned, there are important choices to make today that can tell the stories you will tell your children or grandchildren or great-grandchildren. So who should get their blood sugars tested? Slide 12. Slide 12 gives us an idea. Get your blood glucose checked for prediabetes if you are age 45 or older and overweight. So certainly if you're over 45, and this is from the American Diabetic Association, and you're overweight, and I can define what we mean by overweight, but if you are 45 and older and not overweight, then there should still be a discussion with your doctor or healthcare professional if you should have your blood sugars done. And age under 45 but overweight and increased risk of diabetes, then you should get your blood sugar tested. So I'm going to just come off that slide for a minute and just talk about over 45 and overweight. So how do we define if you're overweight? Well, it's based either on your body mass index, your BMI, which is your weight in kilograms over your height squared in meters, and the BMI roughly between 20 to 25 is considered normal, although the WHO now classifies it slightly differently. If you're of Asian, that's Indian and the Indian subcontinent, and of course, for many of us in this country, our ancestors came from India. Our ideal BMI is actually 23 and below, not 25. So if you're 5'7", your ideal body weight might be about 155, around there, 155 to 160. I'm just saying at the top of my head. So you need to define ethnicity where overweight is concerned. But also, we talk about waist circumference. So you may have an ideal body mass index, but you find that a lot of the fat tissue is around the tummy area, what is called abdominal adiposity. And of course, as we get older, as men and women, as particularly after the menopause, as estrogen levels drop, you tend to lay down fat around the tummy area. And I know a lot of my female patients come in and they're battling with that. And, we have to show empathy, not judgmental in our consultations, not talking down to our patients, but trying to be encouraging and coming alongside our patients and recognizing that a lot of our patients are trying to lose weight, but they battle with weight loss, which hopefully I can talk about. So what are some of the other risk factors? Slide 13, I think it is, slide 13. So very important, a parent, brother or sister who has diabetes. If you're even under 45, I would say from 30 and above, and you have a parent, or if you have even a greater genetic link, 2 parents with diabetes, father and mother, brothers and sisters with diabetes, that puts you in a high-risk category. Now, these ethnic groups are more American-based, Afro-American, but Afro-Caribbean population can apply. Hispanic or Latino, Native American doesn't apply to us. Asian American, what are Asian Americans? That's talking about people from India, Pakistan. So we fall into that category. And the Pacific Islanders are people from Hawaii, etc. If you had a baby weighing more than 9 pounds, or you had gestational diabetes, you are in a high-risk group. If you have high blood pressure, above 140/90, there's a link to prediabetes and diabetes. If you have low HDL, that's a good cholesterol, 40 or lower, and if you have high triglycerides, 150 or higher, that also puts you in a high risk. So I'm just going to come off that slide. That's quite a mouthful. So what we are seeing is that, and on the last program, and I was going to show back this slide, the last slide I showed, I think last 2 or 3 weeks ago, was a scoring card developed that can score your risk for developing diabetes. And it had things like your age, whether you're male or female, your ethnicity, whether you have hypertension, I think high cholesterol, and whether you had a family history, and whether you have a sedentary lifestyle. I think there were about 7 factors. And if you scored 5 or higher on that scorecard, then you have a high risk of getting diabetes and should be checked intermittently. So we are saying that, one, very importantly, if you have a genetic link, so if you have one parent with diabetes, you have about a 30 to 40% risk of getting diabetes at some stage in your life. If you have a mother and father with diabetes, well, I'm afraid to say you have about an 80 to 90% risk of getting diabetes. And that's the group I have coming in who are completely confused by, why did I get diabetes? I've lived a good lifestyle. I know my parents were diabetic. So I've tried to take steps, exercise, and lo and behold, they go for a blood sugar test, shows up diabetes, and they're quite dismayed over this. Especially if they had bad experiences looking at relatives who developed complications of diabetes, like amputations, kidney failure, ending up on dialysis, blindness. So patients come in with this diagnosis, and there's a lot of fear and anxiety. And part of my job in my first consultation with patients with newly diagnosed diabetes is to allay some of those anxieties. Oh, thank you. Thank you, Josh. Oh boy, I'm going to have to pay Josh a bit extra. I don't pay him, but I think he deserves a little bit extra. So how old are you? So if you're less than 40, 0 points. If you're 40 to 49, 1 point. If you're 50 to 60, 2 points. If you're above 60, 3 points. Are you male or female? Males are at a higher risk. Are you a woman who have had gestational diabetes? You score 1. Do you have a mother, father, brother, or sister? You score 1. Have you been diagnosed with high blood pressure? Are you physically active? What is your weight category? Now, just take a look at that. And if you have a camera at home, I would advise you to take a photo of that. Now, I think 1 or 2 people did WhatsApp me asking for this. And what I'll try and do is take a photo of this and send it out on my WhatsApp to my patients. So thanks, Josh, for that. That's very important in terms of identifying people who are at high risk. So we can just come off that slide for a minute. So you have done a blood sugar test. You have identified those who are at high risk and who should be having blood sugar testing. I know we have to probably go to our second and final break soon, but if you have pre-diabetes, what does this mean? So I'm just going to bring up the next slide, which I think is slide 14. Slide 14. If you have pre-diabetes, what does this mean? Well, you might get type 2 diabetes soon or sometime in the future. You are more likely, and this is the second and very important bit of this, you are more likely to get heart disease or have a stroke. So let's just come off that and talk about that. So why is this condition of prediabetes? Why have I decided to do this program on prediabetes? Well, you know, I am convinced, and in fact, when I did my master's in diabetes, my thesis was on prediabetes and the metabolic syndrome. And I was still in the UK, and I took a cohort of patients coming into our practice. It was a large practice with other doctors, and we looked at various factors that might put people at risk of prediabetes, and certainly ethnicity and obesity was one of those factors. But the important thing about this, there are 2 things. If you have prediabetes, you must be aware that you are on the road to diabetes. Now, I know sometimes, patients come in and they come in with their children. They may be in their 50s and 60s. Their children are in their late 20s or early 30s. Some of the children, when I look at them, they're already overweight. These are young adults. And I turn to the children and I say, well, look, have you done a blood sugar test? You should do one. And sometimes I see a kind of glazed expression from the point of view, well, doc, I really don't, you need to read people's body language carefully. As a healthcare professional, and as a pastor as well, I'm taught to read people's body language quite carefully. Don't be afraid to come and meet me as a result of that. But you read people's body language, and you could see sometimes there's a resistance to accepting the fact that I might be on my way to diabetes, or I might have prediabetes, or I just don't want to know about this because I see what my father or mother is going through. So diabetes is obviously a serious condition. You will obviously be healthier if you delay, or as we're going to probably go into in the final session, prevent diabetes. But the last point on that previous slide was this. Diabetes puts you at a higher risk of developing cardiovascular disease. By that I mean coronary artery disease, so heart disease and strokes. So from a pre-diabetic state, you're beginning to clog up your arteries. From a pre-diabetic state, you're beginning to develop atherosclerosis and an inflammatory response. So now we are talking about cardiovascular disease and even diabetes in terms of inflammation of the arteries. And that's why some new treatments are coming in to look at this whole aspect of inflammation of the arteries. As you know, diabetes has moved on from being a sugar disease to being a cardiovascular disease. So if I can intervene, sadly, recently I have a good friend who's only in his early 50s who's developed a stroke, and I understand when he went into the hospital, he was told that he probably had 2 or 3 previous strokes, and the one that presented was another one. So that person is only 52, should not be going through that. That could have been prevented by good blood sugar control, good blood pressure control, and good cholesterol control. So the whole idea behind looking at prediabetes is not to medicalize a non-medical problem, but it's to highlight the fact that this is almost a pre-diabetic condition, but it can lead to serious consequences if left untreated. We're going to go to our second break and return to Your Health, Your Choice. You can ring us on or WhatsApp your messages on 482-4269. We go to our second break and return in a minute or two.
Exclusively on ACTN The Voice. This is Messenger TV. Join us as John and Lisa Bevere equip and empower generations of Christians, both young and old, developing uncompromising followers of Christ who transform our world. Starting on Mondays at 8 a.m. with repeats to fit any schedule. Tune in, log in, or click on the Word like never before. Stay tuned for a new experience from the Word of God with Messenger TV. Exclusively on ACTN The Voice.
You're watching ACTN, The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice. You're watching ACTN The Voice.
Welcome back to Your Health, Your Choice. Again, as we come to our last segment for tonight's program, we are pre-recorded, so you can ring us on WhatsApp your messages on 482-4269, but that's the number for my medical office. Appointments, and if you need to find out more about the Anaposis Chapel, you can call us on 482-4269. So we have talked about prediabetes. How do we define it in terms of the blood sugar testing? Why is it important? Because it's on the road to developing diabetes with all its complications, and also it's a condition which can predispose you to early cardiovascular disease. So how can we prevent diabetes? If we, identify someone with prediabetes, what do we do? I think it might be slide 15. Let's try bringing up slide 15. Slide. Okay. Was that from last week or this week? Slide 15 on the next slide, Josh? Right, yeah. So I'm not sure if that's slide 15 or 16, but we'll just go in order now. So how do you delay or prevent type 2 diabetes? Well, the two important things. There's absolutely, we can try to sugarcoat this. We can try and tell you otherwise, but regular physical activity, such as walking almost every day, and weight loss, two important principles. So that's going to come off that slide, because I want to spend 1 or 2 minutes on this regular physical exercise. In fact, let me just go to the next slide, and I'll then be able to summarize this a little bit more. So there was a study called the Diabetes Prevention Program, and it showed that 30 minutes a day of moderate physical activity, along with a 5 to 10% weight loss, produced a 58% reduction in diabetes. Now, just taking those figures for a minute, 30 minutes a day of moderate physical activity, along with a 5 to 10% weight loss, produced a 58% reduction in diabetes. So just come off that slide for a minute, and let's just think about that. So a lot of patients have come in to me recently after, well, unfortunately, we are seeing a resurgence of some COVID-19 cases, but as the country has reopened, patients have started coming back in, and they have said, well, during COVID-19, I couldn't exercise, I couldn't go outside, and I then very gently pushed them towards the fact that even if the country is closed down, we can exercise. You can develop an exercise program at home. Now, I was fortunate, even when we were not allowed to exercise on the road, I was able to run around my house. And in fact, so again, halo over my head, I'm now exercising more than I've ever done. So I'm at that age. I'm not going to say my age tonight, but I'm at that age where if you're not careful, you can lose a little bit of muscle mass. And I point this out to patients. When you exercise, you're not just doing it for your diabetes. Exercise helps your sense of well-being. It releases endorphins. So if you're feeling a bit low and you exercise, you will find that your mood can be improved. It might increase even serotonin and dopamine levels. It also helps with muscle mass, very important. So men, probably more than women, but even with women, as you hit the menopause and you go through the menopause, you don't just lose bone mass, but you can start losing muscle tone. And men, of course, as our testosterone levels fall, and that's a reality, after 21, all of us as men, our testosterone levels begin to fall, and you begin to lose some muscle mass. So doing exercise, so moderate exercise. So how am I doing it? So up to yesterday evening. Now, I have to say I'm a very obsessive, ordered person. I get up in the morning, I have my cup of coffee, I go to my back garden, I sit on my bench, I read my Bible, I pray, I send out messages to our church, our congregation, and others, and then I have a routine. So 6 o'clock on evenings now, that's my time. Now, not everyone would be able to be as scheduled as that. But because I've developed that habit, when 6 o'clock comes and I'm not exercising, I feel that I'm missing something from my schedule. So I don't have my Apple Watch on. I was supposed to wear it today. But what I do is I put on the walking program so I can track what my heart rate is. So sometimes my heart rate might go up to 130 to 140 when I'm exercising, especially now that I do a little bit of running with it. I'm not expecting all of you to do that because you have to build up slowly. And then I get back home, I do some squats, I do some stretches, touching my toes, and then I do some push-ups, some sit-ups, and I do a little bit of resistance training to make sure the muscle mass is, well, not like some people, but at least I'm trying. But the point I was going to make about this is, especially your leg muscles, your quadriceps and your hamstrings, very important to strengthen those muscles. I have a lot of elderly people coming in their late 60s and 70s, some of them on walkers, some of them swaying and not be able to keep proper balance. And at that stage, very often patients, they want vitamin B12 injections or some kind of injection. They want some multivitamin supplement. Can I just say that giving tablets for every symptom is not always the answer. So while I am a big believer that there are many conditions that we need to prescribe, so you have some healthcare professionals or some alternative practitioners who would tell you to do away with all your meds. Now, I think that is highly irresponsible, very dangerous, especially for diabetics. I want to just give a little bit of a warning. There's some YouTube videos coming out from I think a doctor in Germany, and saying to people that they can cure their diabetes with diet and exercise alone. Listen, that is a misunderstanding. Yes, some people can reverse their diabetes with stringent diets and exercise, but if you have a strong genetic component and if you're a late presenter with type 1 or your beta cells are burnt out and you come off your insulin, you can die. Yes. So you have to be careful. But let me just come back to the exercise. So I'm really pushing at you. If you want to reverse your pre-diabetic state, exercising about 30 minutes a day, and this is not just a gentle walk down the road. You really need to push yourself. That's why I'm not telling you have to buy an Apple Watch, but you have the Fitbit, so you don't even need one of those. But you need to know that you're raising your heart rate a bit, and you're sweating a little bit, If you walk down the road and you haven't even had a sweat, you have to question whether you have really extended yourself. And so you do that about 30 to 45 minutes, and then you do a little bit of resistance training. And of course, weight loss. Weight loss is very important. So we are saying that losing 5 to 10% of your body weight. Now, this is assuming that you're overweight. So it's well known that many diabetics have eating disorders. So if somebody's, especially type 1 diabetics who are quite slim, I don't want them to lose weight. And in fact, I have a few type 2 diabetics who have done very well. They have lost weight. And I say to them, I don't want you to lose any more weight. So the next slide, which we can bring up, talks about losing 5 to 10% of your body weight. But there's a proviso here, because I looked at this slide and I'm showing it. But if you are 150 pounds and you're 6'2", you're actually not overweight. You might be actually a little bit underweight. So even if you're 175 and you are over 6 feet, that might be an ideal body weight for you. But if you are 150 pounds and you're 5 feet, then that's overweight. So let's just come off that slide now, Josh. And so I think that slide is a little bit misleading in that it's just giving you your weight. What you need is your body mass index. And it is well recognized that if you are in the overweight, so if your BMI is between 25 to 30, or you are in the obese category, and I know obese is not a word we like using, but there's obesity grade 1, 2, and 3, and then there's morbid obesity when your BMI gets above 40. If you were to lose initially, if you're in the lower category, maybe BMI between 25 to 30, if you lose about 10% of your body weight. Now, I'm saying lose 10% over a period of about 6 months. So I'm not asking you to lose 10 pounds in 2 weeks or 3 weeks. I'm saying over a period of time that you are able to put things in place, you start eating healthily, you start exercising, then you can lose 2 or 3 pounds every week and you can meet that goal. So losing your weight, very important, especially weight from around the tummy area. So the next slide says, simply poses you a question, and it's an important question. How much do you weigh? How much do you weigh? When last did you weigh yourself? And I'll come off that slide quickly. So why? Why am I asking you that? Because I'll tell you, your weight can go up very gradually as you get older, and you don't realize it. I have to say to you that many of you know I'm very open about this. I had colon cancer 2 years ago. I'm cancer-free. I'm due for my 2-year checks. By the way, if you're over 45, the standard protocols now is that you should consider having a colonoscopy every 10 years or so. And that's done by a gastroenterologist because colon cancer is very common. But I did lose about 25 pounds, and because I was about 185 and I came down to 165. Now I've put back on some weight, but I'd like to think some of that weight gain is muscle. I'd have to ask my wife if that's the case. By the way, she's not on the program with me over the last few weeks because I've been doing these programs on diabetes. When we get back to some of the more wider topics, I'm sure she'll rejoin me. So the next slide, and I know we are coming to a close of the program, strategies for losing weight. Strategies for losing weight. Cut back on calories and fat. So the high-fat foods, the chocolate cake and the carbs, you need to look at the carb intake. What do I mean by carbs? The amount of rice, roti, macaroni pie, pasta, flour, doubles. Doubles, one of our favorites in Trinidad. And be active most days of the week. So you have to push yourself to get off that couch and get out and do some walking. Even if it's in the rainy season, try and do some walking. Don't let the rain deter you. Eat breakfast daily. Breakfast is an important point. I have to say that's not one of my strong points. I tend to have a very, very light breakfast, sometimes just coffee, which is not good. And then I eat lunch quite late in the afternoon. And keep records. So this is an important point. Keep records of what you eat and drink, daily physical activity, and your weight. Now, why am I asking you to keep a record of your weight? Now, especially if you're pre-diabetic and you're seeing a doctor, you come into the doctor and the scales may tell you, very often a different figure to what you're at home. So I often say to patients, if there is a challenge with weight, it's a good idea to invest in a scale for home. A good scale, it could be an electronic one or otherwise, and then you monitor your weight and don't become obsessive about it. You can do your weight maybe once every 2 to 3 weeks. But if you're actively trying to lose weight, if you have set a target and you're trying to lose weight, then it would be wise to record your weight. So just as how we record your blood pressure, we record your blood sugars, it's a good idea to record your weight. I think this is about slide 17 or 18, Josh. Let me just see if one of the slides that comes up, we can try slide 18. Slide 19, we already covered that. Slide 20, or we're coming to an end. Slide 20, you can go to the next slide. 21. So implementing a weight loss program on your own or through an organized weight loss program. I know I'm a little bit cautious about weight loss clinics, but they're Weight Watchers. A combination of meal planning and physical activity is most successful. The next slide. Records, write down everything you eat and drink. Well, don't be obsessive about it. Your physical activity, that's important. What kind and how long your weekly weight. The next slide, I'll end with the next slide, the slide after this. This is called keeping a record. So tips for heart-healthy eating, and probably I'll try and circulate this as well, which is your game plan. Eat smaller portions, choose non-fat or low-fat dairy products, choose lean meats, remove skin, eat at least 5 servings of vegetables and fruit every day. Skip some of the desserts, ask for low-fat dressings, and increase your activity, and take the steps. Work out in your yard and garden. So I'll probably take a photo of this, or we could just leave it up a minute. And if you want to take a photo of this with your camera, with your phones, we now have our phones with cameras. That's a good one to try and keep in mind. I think we are winding now down to the last 3 minutes or last 2 minutes. So just to say, finally, there's one drug that we can use in the pre-diabetic state. I use metformin or glucophage, and especially people who are overweight and who are maybe their A1Cs are close to 6.5 or above 6, or their fasting blood sugars are nearer to 126. So I would very carefully choose patients who I think would benefit from metformin or glucophage. So there is a role for drug therapy. Some people talk about cinnamon, fenugreek, chromium, and some supplements like that. I sometimes suggest people try those things. The science behind it is still not all there, but it's something to try. I know some of you may have questions, so you can WhatsApp us on 482-4269, 482-4269. But I will try and circulate on my Facebook, my timeline, 2 of those slides that I showed today, because I think there was some interest. So this program shows on Wednesday nights. We're also on Facebook. I think it's uploaded to Facebook some weeks, and also on YouTube, the ACTN, The Voice. So as I end today, I put on my pastoral hat. Over the last 2 weeks, I've been talking about the grudge. The grudge. How do we deal with offenses in our life? You know, there are some people who are on the lookout for an offense. And if you are looking for an offense, you will be offended by someone. It's inevitable in life. And 2 weeks ago, I talked to our church about small offenses. And if you don't get over those offenses, it begins to build up bitterness in your life. And the point I made is that our calling in life is far too great to be kept down by small offenses. But last Sunday, gone, I talked about the big offenses, the betrayals, people that you have trusted in life, people who are close to you and have placed a knife in your back and have betrayed you. How do you forgive those people? Can I say forgiveness is not forgetting? And when you forgive, you're forgiving, and I want you to remember this as we close. You're forgiving because you have received forgiveness from God. So the gospel, the good news of what Jesus came to do was not just to give us forgiveness, but to allow that forgiveness to flow through us to others. And can I say as I end, forgiveness is more for you than the person forgiven. Forgiveness releases you from the poison of bitterness. It allows you to live in freedom. It allows you to soar and achieve all that God wants you to achieve in life. Thank you for joining us on Your Health, Your Choice. I'm Dr. Claude Kahn. This program will be replayed for 2 weeks, and we will return with another program in about 2 weeks' time. This is Your Health, Your Choice.